Hello, I'm Dr. Ralph Abraham. I'm consultant diabetologist and founder of the London Diabetes Centre in central London. I started the London Diabetes Centre 27 years ago because I felt that there was a real clinical need for a diabetes centre that catered for all the needs, all the possible needs for every single different kind of patient who has diabetes. And so today, in 2019, we have a centre that deals with children as well as adults, with every single different type of diabetes, from those who need insulin to those who need weight loss, and which actually has the equipment and expertise to deal with all the complications of diabetes, from the eyes and the heart and the feet to the arteries, the kidneys and the liver. And to be able to not only offer patients the facilities for the diagnosis and treatment, but to provide the connected, joined-up thinking that I think is so essential for good care in diabetes. Ophthalmologists, like many doctors, were trained in an era where the main aspect of diabetes care concentrated on blood glucose control. And so they know the very strong association with long-term high glucose levels and damage to the eyes. And damage to the eyes not only in terms of the front of the eye, which is the cornea and cataracts, but also the back of the eye and the retina. What they probably don't realize anymore is the great interest we have in other metabolic abnormalities that accompany diabetes. Ophthalmologists will of course know the importance of maintaining a good blood pressure control in perhaps preventing retinal disease, and many of them are aware of the influence of lipids in controlling good lipid disease, good eye disease. In fact, the same recommendations that are made for the control of arterial health and diabetes elsewhere in the body, which have been shown in many clinical trials to be blood glucose control, good cholesterol control and good blood pressure control, actually also apply to good eye health. And perhaps it's not their fault that they only refer back to diabetologists who look after the sugar. There is of course enough of a problem in getting good glucose control in the past, and we always tended to blame patients for poor control. But most poor control is caused by inadequate medication, inadequate support from healthcare professionals, inadequate education offered to patients, and probably inadequate execution of modern treatments to care because of resource restrictions. So it is possible in the year 2019 to actually achieve outstanding glucose control. Unfortunately, it might be 5 or 10 years before ophthalmological colleagues begin to see that benefit. In the meantime, we have to make sure that diabetologists and GPs also do not forget good blood pressure and good cholesterol control, because they also play a part in eye disease.